The idea was to do something for depression and other mood disorders like cancer centers did for cancer. The treatment of depression has evolved tremendously over the last couple decades. There wasn't much known about the biology of depression or the neurophysiology of depression, the genetics of depression, what happens in the brain when people get depressed. But now we know that it's a disease that is something that many different paths can lead to.
We still, as a culture, I think, see elements of psychiatric problems as weakness or character issues. When you find yourself in the grasp of a major depression, it's not as simple as the bootstraps, pick yourself up, dust yourself off, and get on with it.
Depression is one of the most common illnesses that people experience during their lifetime. About 1 out of 5 people will experience it sometime in their lifetime. And when it hits, it can be devastating.
Depression is one of the greatest causes of lost productivity of any illness. So psychiatric research has a lot of catching up to do, because it's only been relatively recently that we've been able to have the capacity through sophisticated neuroscience techniques to look at the brain while it's working.
Of course, we know a lot about medication now that we didn't know about 25 or 30 years ago. There have been many new drugs developed, but yet there are a lot of people that don't get benefit from medication. And so we're looking at newer treatments. We've had several federal grants to do research on computer-assisted therapy for depression. There are 4 centers involved. University of Louisville, which is the center of it all, and University of Pennsylvania in Philadelphia, University of Pittsburgh, and the University of London in England. In this study, we're comparing standard treatment where the patient sees the therapist for about 50 minutes for a session, compared to computer-assisted therapy where they work some on the computer and then they see the therapist for somewhat less time. We don't try to cut through the human contact. We still have doctors that are seeing patients and doing their work, but the computer programs augment that or support it. And the whole idea here is to see whether we can deliver treatment to more people with less resources. It's quite hard to get a large NIMH grant, but younger researchers that are getting started, or even researchers that have been around a while, need that basic support to get going. And without some kind of funding at the local level, that just doesn't happen.
I am a victim of suicide. My mother is gone. I have no way of bringing her back. I think she was depressed off and on probably most of my life, but she was very functional. What she wasn't able to do was to let the guard down enough to get help. And one day she made this choice. She must have been so low, I can't even imagine.
My daughter committed suicide when she was 19, and so my grandchildren, they know this. She had a disease and it was in her head instead of another part of her body. It's sad that people don't get the help when they know they can get the help, when they know the help is available, because a lot of people can't ask. So that's their way of asking.
Investing in the Depression Center has an impact in a variety of ways. The first step of that is really allowing us to bring more cutting-edge clinicians and researchers into Louisville so that we can stay on the cutting edge of research and clinical care. It will attract even more individuals who want to be on the cutting edge. So the way I look at philanthropic support is that it's not a gift, it's an investment.
There isn't a way that we can do the kind of education and cutting-edge research that needs to be done simply by business as usual. It doesn't really cover anything else that would take us to a new level of treatment. So that's what's really needed.
In the national network of depression centers, we're in some very sophisticated company, and many of them are private universities which have sources of support far beyond what a public university has available.
I'm very interested in looking at clinically, can we change care, can we redirect systems to really begin to take care of patients in a way that makes sense and uses our resources wisely, particularly as resources continue to be cut. That's where research can really help us move forwards with all the changes in healthcare. Our department is very invested in educating the next generation of leaders in psychiatry, not just the next psychiatrists, really people who want to go out and do more.
And the great thing about the Depression Center is that they are teaching the next generation of mental health professionals. And so more and more, what we hope to see is that it will not just be health and mental health, but that people will understand that health means health, top to bottom, head to toe.
We have among the best minds in depression in the United States. And with more resources, more of those people will want to work here in Louisville with us.
It is hard to toot your horn when you're doing work with a condition like depression, or when you're practicing psychiatry and other mental health disciplines. We don't have the great drama like a heart transplant or a bone marrow transplant or something of that order, but really in our daily work and when we see patients, there's a tremendous amount of drama. People's lives are at stake.